Kyphosis is defined as an increase in the forward curvature of the spine that is seen along the sagittal plane, whereas lordosis is an increase in the backward curvature seen along the sagittal plane. When the forward curvature becomes excessive, this is called hyperkyphosis. The presentation can vary and may be caused by degenerative changes in the intervertebral discs. The curvature can be normal variance when presented in the thoracic spine, or in excess be a cause for instability and concern. There's three main types and causes of kyphosis. 1. Postural kyphosis. Common in adolescents, more in females. Caused by slouching posture, which weakens back muscles and ligaments over time. Vertebrae are normal, and the condition is usually benign, not serious. In older adults, weak muscles and osteoporotic compression fractures can increase the spinal curve. 2. Scheuermann's disease, juvenile kyphosis, structural deformity of the thoracic or thoracolumbar spine occurring before puberty. Caused by abnormal growth and ossification of the vertebrae, right pointing arrow anterior wedging. May have a genetic or hereditary component, seen in identical twins. 3. Congenital kyphosis. Present at birth, uncommon but can be severe and progressive. 2 types. Type 1, failure of formation, vertebrae fail to develop properly. Type 2, failure of segmentation, vertebrae fail to separate. Often diagnosed after the child begins walking. Can cause spinal cord compression, second most common cause after tuberculosis. There's also other causes of kyphosis like aging, spinal injuries, osteoporosis, spinal infections, slipped disc and malignancies. Clinical features of hyperkyphosis. 1. General, common signs and symptoms. Rounded back, cosmetic deformity, due to excessive forward spinal curvature. Visible, hump, on the upper back, especially when viewed from the side, back pain, mild to severe, pain worsens with movement. Fatigue, forward head posture, uneven shoulder height. 2. Severe, advanced cases. Chest pain, shortness of breath, due to reduced chest expansion, weakness. Loss of sensation, numbness, tingling, bowel and/or bladder incontinence. 3. Physical examination findings. Observation, rounded upper back, hump, more obvious in severe cases. In mild cases, the hump may not be easily seen. Palpation, tender paraspinal muscles, tight hamstrings, especially in Scheuermann's disease, act as lumbar compensators. Range of motion, ROM, normal ROM, flexion 90 degrees. Extension 30 degrees, lateral bending and rotation 30 degrees each. In hyperkyphosis, stiffness and reduced range of motion. Flexibility test. Postural kyphosis, curve straightens when lying down equals flexible spine. Structural kyphosis, Scheuermann's, curve remains rigid equals not flexible. Doctor's management for hyperkyphosis divided into 2, which is conservative non-surgical management and conservative surgical management. Conservative non-surgical treatment includes 1. Observation 2. Physical therapy 3. NSAIDs, pain management 4. Osteoporosis treatment for age-related kyphosis 5. Bracing. Surgical treatment 1. Age-related kyphosis, due to osteoporotic fractures, kyphoplasty or vertebroplasty. Minimally invasive procedures. Purpose: stabilize fractured vertebrae and relieve refractory pain. Do not correct kyphosis fully. Surgical treatment for the Scheuermann's kyphosis include traditional, anterior release and fusion plus posterior instrumentation with fusion. Modern trend, posterior-only approach, offers greater curve correction and is increasingly preferred. Surgical treatment for the congenital kyphosis include always requires surgical treatment due to progressive nature and risk of neurological damage. Approach depends on age and curve severity. Doctor's choice depends on the child's age and curve severity. Children younger than 5 years, with curves less than 50 degrees. Doctors perform posterior fusion. Children older than 5 years, with curves greater than 60 degrees. Doctors use a combined anterior and posterior fusion approach. If there is spinal cord compression, anterior cord decompression with fusion is required. Physiotherapy, exercise-based management 1. Postural awareness and training, teaching the patient correct upright alignment, thoracic spine not overflexed, shoulders back, chin, tongue alignment, and making the patient aware of hunched posture. Evidence: a functional exercise program in teenagers significantly improved thoracic kyphosis angle compared to control. Also, systematic reviews suggest that exercises targeting posture and spinal alignment are effective in improving sagittal posture. Physiotherapy, exercise-based management 2. Strengthening of back extensor muscles and core stabilizers. Because many people with kyphosis have weak spinal extensor, erector spinae, multifidus, muscles and poor trunk stability. Example, in the RCT of older adults, the exercise program included spine strengthening and posture training, 3 times weekly for 1 hour over 6 months, and resulted in measurable reduction in kyphosis angle. So the physiotherapist will include back extension exercises, prone, Superman, type, resisted rowing, scapular retraction with hold, planks, bridges for core, etc. Physiotherapy, exercise-based management 3. Mobility, stretching of anterior structures and thoracic spine. Tight anterior chest, shoulder, pectorals, tight hip flexors or hamstrings may contribute to forward flexed posture. Also restricted thoracic extension mobility contributes. Evidence. One single subject case study showed thoracic stretching plus thoracic extension exercise plus cervical, scapular posture exercises reduced kyphosis angle and upper thoracic pain. Mobilization. In a pilot RCT, thoracic joint mobilization plus extension exercise improved thoracic alignment and shoulder function. 4. Balance and functional training. Since hyperkyphosis often shifts center of gravity forward and impairs balance, gait, and increases fall risk, especially in older adults. Exercise programs have also shown improvement in physical function, gait speed, load standing, in older adults. So physiotherapy might include single leg stand, tandem walking, stepping drills, functional reach, combined with spinal, postural correction cues. 5. Education and behavior change. Patients must understand how daily posture, ergonomics, sitting, standing, device use, lift mechanics matter. Also safe movements, avoiding further collapse, especially in osteoporosis-associated kyphosis. Home exercise adherence is crucial. One home-based 6-week study in older adults with hyperkyphosis showed feasibility and effectiveness. Okay, that's all from me. Thanks for watching.